Hello, everyone. Greetings and welcome. When we think about odontogenic lesions as a whole, the tumors, the whole cysts, and everything, they really are about as undisputably oral and maxillofacial as it can get. And they are really a point of interest to us most of the time, more than anything, because in the recent times, I guess, as far as the classification goes, we have been shifting things around, from tumors to cysts to tumors, and from allied lesions to tumors, and back and forth. So there's a lot of interest always. And the new classification, of course, holds considerable interest. We had a session in the conference, and I just thought it's time that we shared that with you for all those who missed the session. Now, with that, yes, and also within the same series, where others which are there on the channel now, and you can see those. So if you want to watch them, you can look on the either go to the channel and look on the IODCPC series. You look under a playlist, you'll find them. And also there is a tiny URL that I have put there, which you can follow, and it'll take you directly to the playlist where you can watch Dr. Keith, Dr. Boko, and Dr. Borges's lectures. These have already all been put up. Now, with that and without any further delay, let's start with today's lecture. Remember, it's a recorded session from the ones that took place during the IODCPC, and I hope you will enjoy it. All
Dr. John Wright is a Regents Professor in the Department of Diagnostic Sciences at Texas A&M University College of Dentistry, USA. Dr. Wright is an oral pathologist of international repute whose contribution to head and neck pathology is extensive. His role in developing both the 2017 and the 2022 WHO classification of oral disease and current co-editorship in the upcoming AFIP fascicle series on head and neck pathology are testament to his internationally acclaimed expertise in the field of oral and maxillofacial pathology. It is an honor to welcome Dr. Wright to deliver his lecture.
Hi, everyone. I'm John Wright, and it's an honor and a pleasure for me to be part of your program today. The new WHO classification is out, and to the extent that this dramatically affects our professional lives, I think we need to be familiar with the changes that are coming. I've been involved with the production of both the 2017 and the current WHO classification, so hopefully I'll have some insight to share with you about what's coming with WHO. It's only given 20 minutes. It's not a very much time for any in-depth discussion. There are two publications reviewing this that are considerably more detailed than what I'm going to give today. One was published last month in Head and Neck Pathology with my good friend Marilyn Reed, And this has an extensive discussion of the molecular changes that have occurred since 2017 and will be a lot more detailed than what we will talk about today. And had an opportunity to do a similar publication with my good friend Merva. And this is going to focus a little bit more on the diagnostic features of this group of lesions. But both of these will be in more detail than today. And certainly these are available for you if you want some additional information. One of the biggest changes in 2022 is that in addition to the Blue Book, there will be virtual access. You have to purchase this separately. You don't get this if you purchase the Blue Book, but the Blue Books are not out yet. The virtual is available by subscription, a little bit over $100 US, I think 80 some pounds. But this not only gives you access to all of the odontogenic cysts and tumors and allied lesions, but to all of the Blue Books. So big advantage there. And then I'll say something else in just a minute about the scanned images. So what's different? Well, being online is completely different. You can access this at any time and anywhere in the world. You don't have to carry your Blue Book with you. But one of the biggest advantages is whole slide images of every condition has been scanned. And when we all publish, whether it's publications or books, and we're asked to capture that lesion in 2 or 3 photomics, we invariably go to the areas that are the most characteristic and diagnostic. And quite frankly, that's not what these lesions look like. And so having the whole slides available, I think, has a huge advantage of giving those who participate the added insight into the histologic spectrum of these lesions, because they don't all look classic in all their areas. I'm not sure why malignant has traditionally gone first, but for the first time in all of the tumor series, the benign lesions are going to be discussed first. They are usually more common, and so it'll be that way with the odontogenic lesions. I thought this was quite controversial. In 2005, the language that they used to subclassify the odontogenic tumors, you truly had to be an oral pathologist to understand it. It was unbelievably confusing. I think these classifications need to be simple, and these classifications are not written for oral pathologists. They're written predominantly for the thousands of general pathologists who provide these diagnostic services. So in 2017, we simply went back to epithelial, mesenchymal, and mixed. Obviously, this is ectomesenchymal, and everybody knows what that means, and it's clear, and it will remain that way in 2022. Another advantage, I think, is that every lesion is going to have essential diagnostic features that you must have present to make the diagnosis, and desirable diagnostic features, things we would like to see, which improves our confidence in the diagnosis, but are not essential to make the diagnosis. Despite the significant molecular update of all of these lesions, virtually none of them are diagnostic, except a new rhabdomyosarcoma that was first reported in 2018, and all oral pathologists should be familiar with this. So I will include that in my talk today also. These are our new entities to the classification, not really many. Adenoid ameloblastoma, not new, but new to the classification. Surgical ciliated cysts, not new, new to the classification. This is brand new, first published in 2018. And it's a TFCP2 rearranged rhabdo, usually with FUS or one of the Ewing's genes. And clearly oral pathologists should be familiar with that. We all see from time to time epithelial odontogenic tumors that have these kind of glandular or pseudoglandular structures in them. And this has been our literature for quite some time as adenoid ameloblastoma. And for the first time, it was decided to put this into the classification as a standalone tumor. And it is called adenoid ameloblastoma. And the diagnosis is based on these glandular or pseudoglandular spaces. I believe for years after seeing some of these that these glandular spaces are really not a differentiation phenomenon. You get these by default. And I think it's due to stromal degeneration. And we can see some blood vessels and collagen here. And all of this is going to degenerate and drop out, leaving this gland-like space. And we can see a few capillaries here. And I think all of this is the result of stromal degeneration. And there's another area there. Some of these have dentinoid, some do not. So the literature will have adenoid ameloblastoma with dentinoid or just adenoid ameloblastoma, but not necessary for the diagnosis. But we do see dentinoid in some of these tumors. And a small percent of these, we find a few ghost cells. And this may or may not have some relevancy also. We do know that adenoid ameloblastomas do lack the BRAF mutations that characterize ameloblastoma. Now, clearly, not all ameloblastomas are BRAF mutated. It's just our most common mutation. But at least the sequencing that's been done on these so far has shown a lack of BRAF mutations, suggesting it may be different from ameloblastoma. These may produce dentinoid. We usually don't tolerate that in ameloblastoma, and they may or may not have ghost cells, and I would argue we do tolerate a few ghost cells, and at least I still make the diagnosis of ameloblastoma. We sent some cases down to Carolina Gomez in Brazil, and she had some and got them from around the world, but she sequenced a number of these and was able to demonstrate some CTNNB1 mutations. Surprisingly, further evidence that these may not have anything to do with ameloblastoma at the molecular level. Clearly, as you would suspect, we can see beta-catenin nuclear reactivity in some of these, reflecting that pathway. And again, this is a lesion that I think, now that it's in the literature, needs further refined and perhaps a name change, because these may end up really not sharing many features with ameloblastoma. Everyone sitting in the audience knows about this lesion, not controversially at all, in fact, really not challenging. But surgery in the maxilla, and you implant sinus mucosa and develop a cyst, and it's lined by respiratory epithelium, and they're called surgical ciliated cysts of the maxilla. And the diagnosis is relatively straightforward. This is just normal sinus mucosa. I'm sure most of you are aware that if you cut first on the maxilla and then go down and do a procedure on the mandible, that you can, and use the same instrument, you can transfer that antral mucosa into the mandible, and we can get surgical ciliated cysts down there also. But this is clearly not new, but it is new to the classification because it is a unique lesion for our area of pathology. Well, in 2018, there was a brand new rhabdo reported, and it was based on this unique transformation with the TFCP2 gene. And there's been subsequent work done on that, and where we are at least today, these are highly aggressive neoplasms. They have a strong predilection for the young. They have a strong predilection for bone. When I see a spindle cell lesion or a sarcoma in bone, I'm thinking osteosarc, not rhabdo. But they do have a strong predilection for bone, and about a third of all the lesions that have been published, in fact, have occurred in the jaws. And that's reason enough for us as oral pathologists to clearly be cognizant of this new rhabdo. I have not seen one of these. A very good friend of mine, Bob Foss, has shared this with me, and this is a lesion that he had, came out of the maxilla. Here's the soft tissue extension. Pretty straightforward histologically that it is a high-grade sarcoma. They are usually biphasic. They have a spindle cell component and areas of a more epithelioid component, but pretty embryonal looking, high cellularity, lots of mitoses. Everyone would think malignant. And many of the areas are predominantly spindled. And again, if I see something like this, I'm looking for osteoid, but not any produced here. And then usually a component of more polyhedral or epithelioid looking cells with lots of mitoses. And again, we can see the mitotic figures here with kind of rounded or polyhedral cells. And that biphasic pattern is fairly characteristic. And again, I would not have usually thought of rhabdo for tumors like this coming out of bone. This is an area of a diagnostic pitfall in that they are cytokeratin positive. And if you limit your IHC panel, you could easily diagnose some of these as spindle cell carcinoma. But they do react with cytokeratin, but they react with muscle markers. And you can see the nuclear myogenin reactivity, extensive reactivity here. As predicted, they're going to be desmin positive, again, desmin and cytokeratin positivity. In most of these, ALK is upregulated and overproduced. I don't know that you really have to do this to make the diagnosis, but if you do, you can usually see some ALK reactivity with these, and that's what the new rhabdos look like. The definitive diagnosis, unfortunately, is going to have to come from molecular. And it's going to have to be done by sequencing or FISH, but you can see the break apart probe here. And that is not available worldwide in a lot of places. So certainly if you have access to this and have histology that looks like this coming out of bone, you could perform this test. But this is the only tumor in the classification that in fact is defined by its molecular footprint. And under the diagnostic molecular pathology, it really needs to be confirmed at the molecular level to definitively make that diagnosis. Controversies. I implied earlier that I don't think these are really written for oral pathologists. These are written for general pathologists, and it is because of that that this classification tends to come up a little bit short. And everyone in the audience, if you got any experience at all, you can probably find areas either now or in the past where you've disagreed with WHM. And that's okay. I'm going to share with you the problems that I have. You may have your own list. You may have things that you think are wrong that I'm not going to list. But I don't look at these just as controversies, but as areas of opportunity for us, where we can do further investigations to help clarify these lesions and redefine them. But we're going to go quickly through all of these, which I believe are controversial. In the first three iterations of the classification, there was a metastasizing / malignant ameloblastoma, and it was categorized with the malignant tumors. In 2017, the word malignant was taken out, and this tumor was put over in the benign category. I was strongly opposed to doing that. I got outvoted. It is hard for me to believe that something that frequently mets to the lung and kills a third of the patients with this tumor should be considered benign. And I believe that through a microscope, the cells look bland and normal, but they're going to prove to have a malignant genotype. And I think the answer to this is going to have to be worked out at the molecular level, but even though they look like conventional ameloblastomas, I believe that at the molecular level, they're going to be very different. And I believe that a tumor that mets and kills people shouldn't be benign. And hopefully this will be put back into the malignant category in short order. One of the more controversial things that we did in 2017 was to say that most AFOs were likely to develop into odontomas and were therefore developing odontomas. We really took it out of the classification. We acknowledged up front that there may be a small number of these that in fact are neoplastic, so maybe we should have left in a neoplastic one, but we did take it out, and I can't believe the pushback we got on that. This turned out to be unbelievably controversial. The IAOP decided to have an international debate about whether this was a neoplasm or a developing odontoma. I was part of that debate. Merva actually came up with this really clever introduction for us. The WHO says hamartoma because we said it was odontoma, but who in the audience says neoplasm. And I can tell you that at least in the United States, oral pathology is one of the most highly respected professions we have. Everybody in the country follows oral pathology. And I can't tell you when the IOP canceled that debate, it was big news in our country. And people were really sad about this. It was not the only thing happening that day in the news. There was a pandemic ravaging the earth, but this was the big news that day. Well, we were thrilled when the IAOP resurrected this debate, and we in fact did decide to have it. And again, it wasn't the only thing happening. They were developing vaccines against the virus, but this was really quite important. That debate was carried off this summer very successfully. And quite frankly, I can't even remember who won. We do know that the BRAF mutations in AFO are a lot more like AF than odontoma, so certainly some molecular evidence that perhaps these are neoplasms. Merva and Marilena wrote a really nice paper last year in Head and Neck Pathology, looking at how to predict possibly whether these are neoplasms or developing odontomas. And this kind of makes conceptual sense, but the younger they were, the more likely that they really were neoplastic, and the larger they were. I think the ultimate answer is going to come at the molecular level and what odontogenic pathways are blocked and which are not. And I think we'll have the answer to this, but we really do not. I can't tell you what percent of these lesions are neoplastic, but I do believe it's a minority. I think most of these lesions are going to develop into odontomas. This was a little mistake, in my opinion. Under the new CEOT chapter, they talk about a Langerhans cell-rich variant of CEOT. Fair enough. But over in the central odontogenic fibroma chapter, they talk about an amyloid-rich variant of COF. And unfortunately, these are the same tumor. And you can't have it both ways. I don't feel as strongly whether you put it here or whether you put it here, but it can't be in both places. So this needs to be corrected. Personally, I think of this tumor as being a variant of central odontogenic fibroma. We were part of a huge international collaborative study on this, and we put all of ours in the COF category. But anyway, it's listed under both tumors, and it can't be both. So that needs to be rectified going forward. And the last lesion, the sclerosing odontogenic carcinoma, I was against putting this in the classification in 2008. I thought it should have stayed in the literature a little bit longer and get better defined. But again, I was outvoted with that. And it got inserted into the 2017 classification. In the original paper, they said that this tumor, without apparent metastatic potential. Well, words have meaning. And the word carcinoma means epithelial malignancy. And if you have a new tumor that doesn't have metastatic potential, don't call it a carcinoma. And the WHO in 2022, under its definition, said no metastatic potential. So I would argue if this tumor exists at all, it is clearly misnamed. But even if it does exist, I don't know how to make the diagnosis. These are the essential diagnostic features of this lesion coming out in 2022 with thin cords and nest of epithelium and a sclerotic stroma, period. That is all you need. And someone needs to tell me how this differs from the histology of central odontogenic fibroma, because it does not. Desirable is a little mild atypia. Every slide I put on my stage, I can show you a little bit of cytologic atypia. I don't know what this means. The neural involvement is very, very important until you put this into the context of the neurotropism of odontogenic epithelium. And I'm not sure I believe that finding a little bit of odontogenic epithelium in a nerve makes a lesion malignant. I think that's highly controversial. So if it exists, it's misnamed. And if it exists, we don't really have accurate diagnostic features for this tumor. This is a tumor that meets the coming WHO definition of sclerosing odontogenic carcinoma, thin cords and nests of epithelium and a sclerotic stroma. There it is. We signed this out 15 years ago as a central odontogenic fibroma. It was curated, no further treatment was done, and this was followed at least 15 years without recurrence. And I would argue this is not a sclerosing odontogenic carcinoma, even though it meets the diagnostic criteria. Everyone should be familiar with the neuroepithelial structures. Clearly, our most important and most famous one is the organ of Shevitz, but not limited to that. Roy Ebersol had a real nice paper on the neurotropism of odontogenic epithelium. And there's been other papers on this, and it's not limited to this. There's a lot of literature on these structures, and simply finding odontogenic epithelium in a nerve does not make a lesion malignant, in my opinion. This is from the wall of a dentigerous cyst far away from the epithelial lining, and we can see some degenerating dental lamina being incorporated in that nerve. And I do not think that's a developing sclerosing odontogenic carcinoma. This was a lateral periodontal cyst that they curated some of the bone in the margin. And here's a little rest of epithelium right along, button up against that nerve. And this is normal. This is not a sclerosing odontogenic carcinoma. So again, epithelium and nerve to me really does not make the diagnosis. And if you eliminate that, this lesion really has no diagnostic features. So this is an opportunity for more work, either at the molecular level or further divining the histologic aspects of this for diagnostic purposes. But I think that lesion is controversial if it exists at all and needs some more work. So I hope I've left a little bit of time for questions. Once again, to the organizing committee, thank you very much for having me.
So that was an interesting presentation, as we have come to expect from Professor Wright. He clarified a lot of points, and I think it was really nice. Of course, it was short because remembering that it was for the conference where we had given everybody just 20 minutes. So if you all would like a longer, more extensive, more detailed lecture from Professor John, you can leave a comment, and I'm sure he will agree to give another lecture on the topic, and we can have it on the channel. And with that, of course, since he's not here, we can't have a live Q&A, but you can type in your questions if you want, and I will pass them on to him to get you your answers. I have to say welcome to our friends who have been here. And I know there are a number who are watching and are not putting in comments, so we don't know they're there. But the ones who are always there and comment, it really helps because I know you're there and I know you're enjoying the sessions and the interaction helps. So to just bring in a few, we have today with us Dr. Rachel and Dr. Nasser, of course. Hi, and thank you for joining. I know you heard this in the conference. Very nice of you to be here. Dr. Divya, yes, very nice. Thank you. Dr. Ratu from Fiji. Dr. Shraddha. Dr. Arpan. Dr. Afreen. Dr. Rajshekaran. And yes, Dr. Garima, I agree. That does resolve a lot of queries. Dr. Jagannath. Yes, it was actually a great lecture, very much so, Dr. Nasser. And yes, Dr. Garima has a comment. Primordial odontogenic tumor stays as such. So have you seen any aggressive destructive POT? I will have to ask him and get back to you. Yeah, you're most welcome. And you're most welcome, Dr. Kumar, and welcome to the sessions. And yes, so, right. Like I said earlier, there are also 3 more lectures on the channel which have been brought in from the conference to share with everybody. So if you want, you can just look for the playlist and get that. With that, I should now share with you, are there any more? Oh, Dr. Met, good. Hi. Yes, nice to see you here. And okay, let me share the next week's events. So next week we have some captivating cases as case discussions from Dr. Sonal Shah, and you will of course find that. Sorry, I need to. Yeah. You will, of course, find that in the events section on the website too. You will find the details. In fact, now you can even watch them right from within the website. If you get late and you're not able to find anything, go to the website. Every week's program is within the website itself available. So next week is Dr. Sonal Shah, and the week after that is we have that also already set up. If you recall, we had during our anniversary session, we had a PAT quiz, and the winner of that PAT quiz got a chance to present a lecture. And for that lecture, we have Dr. Yamuna Devi, and she also is going to have a case discussion. Again, you can find the details on the website too, and they're also already posted, so you can even set up the reminders as and how you want. With that, I should be wishing all of you all farewell. Have fun. See you next week for a live session. And Dr. Sonal is getting up, is rather staying up very late in the night to do the session so that she can be doing it live for you. So I hope you will join and I hope you will enjoy it. See you all till next week. Have a safe time. See you. Bye.